Hello and welcome to Season 2, Episode 94 of the Physician Assistant Exam Review Podcast. This week we're continuing with the genitourinary system. My name is Brian Wallace. I'm the founder and creator here at Physician Assistant Exam Review, where we teach PA students to dominate PA school and ultimately pass the PANCE and land their dream job. That's really our goal, right? Is to get you through school, through the PANCE, and then get a job and start actually doing this stuff. If you like the show, if you find it helpful, if you like the way I teach, I do things a little bit differently than everybody else. And either you'll like it or you don't. And if you do, I'd ask you to do me one major favor. Can you please share the show with your friends and classmates? That's the way that this show grows. That's the way that I get to keep producing shows, is by having new people come in and listen to them. Plus, it helps them if you find the show improves your grades, improves your scores, improves your understandings. Why not tell other people about it, right? And help them do the same thing. Now, if you'd like to get more episodes, if you'd like to get more content from me, there is the website, www.physicianassistantexamreview.com, which is where I have all of the notes from the podcast up there. You can follow right along. I know some people like to do that. They'll follow along with the show as they go over the notes. It's all listed there for you. A few people have asked me about when I say Season 2, Episode 94. Well, what was Season 1? At this point, it's been a long time, obviously, since Season 1. I may drop that moniker, but Season 1 was my first go through the PANCE blueprint. This show started just over 10, or not quite, almost 10 years ago. It'll be in July. Oh, no, I'm sorry. I'm getting a little confused in my dates. It's just over 10 years. So we're just at probably the 10 years and 6 months mark. And I went through the entire blueprint once. And Season 2 is as I'm going through it a second time and refining it, making the content better, making the teaching better as I get better at this. As some of the content's changed, I'm updating it as I go through. And you can get every single episode, all of them, both from this season and the last season, including Episode 1, which I always joke that I'd love to take down, but I think it's too entertaining to let you guys have it. So I leave it out there. If you go to physicianassistantexamreview.com/podcast, you'll find all information on how to go ahead and get all of the back shows. So if you're missing cardiology, I forget what just dropped out of the feed. I think cardiology is gone. There's a couple others that have disappeared in your regular podcast listener, but you can find them all at www.physicianassistantexamreview.com/podcast. All right. I did get a note from somebody this week asking me to please slow down when I speak, that I'm covering the material well, but they have trouble following me. And so this episode, I'm going to try very, very hard. I do get that critique from time to time, that to ask me just to take it down a notch and slow things down. I think the major problem here is that I listen to podcasts and books at somewhere between 1.5 and 2.5 speed. And then I feel like when I do this show, I talk at the same rate that I listen at. So I think that's part of the problem. So whatever, we will try to improve upon that as we move forward, including in today's show. So last week we covered the kidney stones, we covered a few bladder issues, and some disorders of the urethra. Let's talk about those for just a second. Do you remember what bladder prolapse is? What the term for bladder prolapse was? So bladder prolapse is when the bladder actually falls down into the vagina from above, right? So it's called a cystocele. Can you name two types of incontinence? Two types of incontinence. So we talked about 4 different types of incontinence last week. We talked about urge incontinence, overflow incontinence, functional incontinence, and stress incontinence. We'll talk about one of those in particular today. Next, what would a patient coming into your office look like if they were presenting with a kidney stone? What would they be complaining about? Picture in your mind for a second. What would this patient be complaining about that would make you think, you know what, I think this guy's got a kidney stone? So in all likelihood, the picture in your mind is someone who's kind of moving around, can't really sit still, taking their hand to their side and describing this excruciating pain that runs down their flank. That kind of comes and goes, but man, is it painful when it comes. and they're not sure what it is, but they've never really had pain like this, and it is really painful. That picture should bring to your mind somebody with a kidney stone. Now, is that how everyone's going to present? Absolutely not, right? But one of the things I want you to understand, and one of the things I try to push on this show, is that your test questions are not going to present you with outliers. They're not going to give you the guy who shows up with nausea and turns out to have a kidney stone. That's just not how it's going to go. They're going to give you the person with colicky flank pain. They're not trying to trick you. So yes, we can argue on the fringes about every single presentation sign, but to me, that's an academic exercise, or maybe a clinical exercise. But as far as your tests go, it's a flat waste of time as far as I'm concerned. And my goal here is to get you through your tests, get you through the PANCE. That's really the primary function here. All right, so now that we've done a little bit of questions, got the blood in your brain flowing, this week's priming questions. What type of incontinence does BPH cause? So we listed the types of incontinence just a second ago: urge, overflow, functional, and stress. If you recall what those were in our last show, what type of incontinence does BPH cause? Benign prostatic hypertrophy. On physical exam, which scrotal issue will transilluminate? A hydrocele, a varicocele, or a spermatocele? On physical exam, which scrotal issue will transilluminate? Hydrocele, varicocele, or spermatocele? And our last one for today, what is the name of the reflex that results in the testes being pulled up? Well, this is going to be a good show, right? So basically what we're covering today is male genitalia. And we're going to start with erectile dysfunction. Oh, I skipped the music. Let's just play it now for fun. I don't want anybody to miss out. All right. Erectile dysfunction. Clinical presentation for erectile dysfunction is usually a routine physical exam and direct questioning. Right? Direct questioning. Because people aren't going to bring this up in most cases. In some cases they will. But in a lot of cases they won't. So history here is extremely important. And our causes here can be psychological, nerve damage, or blood flow issues, which can result in nerve damage. So our labs and studies are going to be ultrasound with a Doppler and an MRA. And that's largely to determine the cause, so the cause can be treated appropriately. But again, that detailed history is going to be a big part of this. Because there are some psychological issues. There are some other questions. So there are things like, do you get an erection overnight? Do you wake up with an erection? Do you have trouble with penetration? Do you have trouble with an erection all the time? Sometimes, that sort of thing. So this is something that certainly comes up and should be discussed. And like I said, there are multiple causes here. So that's what you're looking for, is how do we diagnose the different causes so we can treat them appropriately. So there are different treatments. So for starters is exercise. We can increase blood flow, right? That's going to help in a whole lot of ways with a whole lot of things. Exercise is a great place to start with almost any treatment plan. Then you get into the medications. So you have phosphodiesterase type 5 inhibitors, tadalafil, which is Cialis, vardenafil, which is Levitra. And probably the most well-known one is Viagra, which is sildenafil. And what these do is they relax specific blood vessels and allow more blood flow to areas of the body. Another possibility are penile implants, which are implantable devices that will allow a man to get an erection. Next on our list is hypospadias and epispadias. There's not a whole lot to talk about here. I feel like maybe I'm wrong, but most people understand hypospadias right out of the gate. It's a relatively common defect where the urethra ends on the underside of the penis rather than at the tip. Surgical correction may be necessary, but it's often a cosmetic issue. An epispadias is a rare defect where the urethra ends on top of the penis. That might cause a little more problems, right? Just a functional issue. Then we move into paraphimosis and phimosis. These are issues with the foreskin. And it's important so this is one of the things where I talk about differentiating, right? Being able to tell the difference between specific things. So I tend to use Crohn's and ulcerative colitis a lot as an example here. Or what's another one? Cushing's and Addison's is another good one. Couldn't think of it. Those are the two examples I tend to use. Paraphimosis and phimosis are another good example. I should probably write this down. Because you're never going to get a test question, a multiple choice test question, that has one of these answer choices in it and not the other. It isn't going to happen. You're going to have to separate these two. You're going to have to know the difference. And if you do, these are super low-hanging fruit. These are very easy questions to get right. But you can easily skip over them and not know them. But honestly, there's only one thing to know here. So it's worth your time and energy to learn it and keep it. So phimosis is when the foreskin cannot be retracted over the glands of the penis. You cannot pull the foreskin back. This may be normal into adolescence. This gets treated with a steroid cream or circumcision. The treatment here kind of makes sense. If at some point I can't retract the foreskin, circumcision may be necessary. That sort of makes sense. You don't have to memorize that. You have to think about it. So that's phimosis. Paraphimosis is the foreskin is trapped behind the glands of the penis and cannot be reduced. So phimosis, it can't be retracted. Paraphimosis, it cannot be reduced. How is this caused? Why is this caused? Well, typically it's our fault. This is generally speaking a medical practitioner who fails to reduce the foreskin after examination or placement of a catheter. So in order to place the catheter, you retract the foreskin, and then you forget to put it back. And the foreskin sort of constricts around the glands of the penis, and you can't put it back later. If it cannot be reduced, the band of the foreskin must be cut. It's a serious problem. My guess is you won't see a treatment question, but you will see a definition question, a diagnosis question with these two terms in it. Or you could. I'm not saying you will. Obviously, there are millions of things they could ask you. But if I'm writing the test and I'm writing a question about this, I'm comparing these two, and I want you to be able to tell me which one is which. That's the main goal here. Next, we have benign prostatic hyperplasia. You heard me sort of fumble over there. I wasn't sure if it was hypertrophy or hyperplasia, but hyperplasia seems to be the right term. So, advancing age is a risk factor. 90% of men older than 80 will have BPH. Keep that in mind. Again, when we're creating those colorful images in our minds of what these presenting signs look like, you're not going to get a 12-year-old with BPH. It's not going to be an issue. They're not going to give you a wacky diagnosis. They're going to give you an 80-year-old man who has issues with urination, which we'll get to in just a second. Most likely, your hypospadias patient will be a pediatric patient. Not necessarily, because it doesn't have to be fixed, right? But in all likelihood, it'll be a pediatric patient. Your erectile dysfunctional patient will probably be a male over 40, maybe 50 or 60. Does it make sense? Could it be a 20-year-old? Absolutely. But in all likelihood, the majority of cases are in men over 40. All right, clinical presentation for BPH. So a big one is getting up multiple times overnight to urinate. The fancy term for that is nocturia, right? Peeing at night. Hesitancy, meaning trouble beginning to void. Decreased urine flow, so you feel like you need to go, but not a lot comes out. Incomplete bladder emptying. So that would be you urinate, but the bladder doesn't completely empty. There's still residual urine in the bladder. And then frequency, which means that you're going to be in the bathroom more often, more frequently, right? And the reason for that is if you don't completely empty the bladder and there's residual fluid in the bladder, you're going to feel like you need to go more often, right? So if your bladder could normally hold, I don't know, let's call it 300 milliliters before you feel like you need to go to the bathroom. Well, you have that 300 milliliters in, but because the prostate is enlarged around the urethra, when you urinate, it's a little more difficult to get the fluid out, right? It's just a more narrow tube. So what winds up happening is you only urinate 100 or 150 cc's. Well, if you don't completely empty the bladder and you have 150 left in the bladder, well, instead of having to make 300 before you have to go again, now you only have to make 150 before you have to go again. And that should totally make sense. Why? Just the reality of how that works. So this is going to lead to our overflow incontinence, right? If you recall from the last episode of the Physician Assistant Exam Review podcast, we talked about overflow incontinence is when you don't get a full void and the bladder gets more and more full over time. So you retain more and more. There's an increased retention of fluid in the bladder, right, as the BPH gets worse. So eventually you're carrying 5, 6, 7, 800 mLs of fluid in the bladder, and at some point that spills out. And that's that overflow incontinence due to that incomplete bladder emptying when you urinate. And you can see why that would cause frequency and then also cause overnight frequency, and where the hesitancy and the decreased urine flow come from. Make sense? All right, lab studies and physical exam findings. History is important to rule out other possible causes. So they're going to come in. What's their complaint going to be? What's this patient going to look like? What's going to happen here? Think. Don't just listen. Think. You're going to have a 60-year-old man come in complaining they have to get up, or that his wife complains during the interview that he gets up 10 times a night to pee. And you're going to probe a little bit, and you're going to find out that his urine stream is a little slower than it used to be, that he has trouble getting started to pee, and then all of a sudden you're going to start putting the dots together. On physical exam, you may feel a smooth, firm, and large prostate. On rectal exam, generally in the middle lobe. You're going to want to do a neurologic exam. You're going to do a urine culture, because if we're talking about urinary issues, you're going to get a urine culture to make sure there's nothing else going on, right? Certainly a bladder infection can cause all sorts of different symptoms. You'll get a PSA, which is serum prostate specific antigen, and an ultrasound. And you may want to do a residual on the bladder to see what's inside of it after he voids. Again, that's sort of going in a different direction, but if we're treating the patient holistically, not just talking about specifically his prostate, but about his problem, right? Because he doesn't actually care about his prostate. I mean, of course, he does, but he doesn't really care about his prostate. He cares about the fact that he can't pee correctly, and that he's having to go to the bathroom all the time. That's what brought him in, so that's what you're treating. Even though you and I both know it's his prostate, and we'll get to that. Treatment, behavior modification. So we're going to decrease fluids before bed. So again, we're going to work on his complaint, not necessarily about solving his prostate issue. Behavior modification, decrease fluids before bed. If you have to get up 10 times to pee overnight, do not drink for 2 to 3 hours before going to bed. That makes sense. I was just on a program where you had to drink a gallon of water every day. And the problem was not drinking the gallon of water. Drinking the gallon of water was just fine. The problem was when you forgot and it was 9:00 at night and you were only through half a gallon of water. Now, I can physically consume a half a gallon of water over the period of an hour or so before bedtime. It's physically possible. The problem is you sleep terribly because you obviously it becomes a problem, right? So if you wonder what these people feel like, that might be a good way to test it out, is to drink a half a gallon of water an hour before bed. It's uncomfortable and you have to get up and pee a lot. Now, the answer for me was make sure you drink your water during the day and then it's easy. The answer for these individuals is the same. It's not cut out water. It's drink during the day. It's drink when you know you're going to be able to get to a bathroom. Decrease alcohol and caffeine consumption. We know that those things can affect fluid levels, obviously, especially overnight. And then a routine avoiding schedule, right? So why not just plan that out? You know, it's as simple as when I'm with my kids and I'm like, hey, your soccer game's an hour away. I don't know if there's going to be a bathroom there. We should probably use the bathroom before we leave for the game. No, I'm good. I'm fine. I don't need to go. We should probably use the bathroom before we leave for the game. It's an hour away. There may not be a bathroom there. Avoiding schedule makes sense for a lot of people. I'm sure you've used one in the past, but for these people, it may be even more valuable. Medications, we can do alpha blockers to relax smooth muscle. Side effects may be hypotension. That's one that comes up, I feel like, a fair amount, the alpha blockers in test questions, because they want to treat multiple things. Like, so how do we treat a patient with BPH and high blood pressure? And you'll want to put them on an alpha blocker, something like that. That's kind of the way I've seen those come up. I'm not saying that it is how they will come up. Again, I'm not looking at the fringes. I'm not looking at every possible example. I'm just trying to tell you what I've seen. Or different ways of thinking about questions, how they will most likely show up. This isn't, again, it's thinking through. If you were writing the test, how would you have to do it? What would you want to say? What would you want to look for? Another drug class you may consider here is a 5-alpha reductase inhibitor. These will block the production of DHT, which causes BPH. This is like finasteride and dutasteride. Not sure there, sorry. And then surgery. That's kind of more my where I come in. Not that I do a ton of these. I don't really work with the urologist very much. They have a resident who works for them unless the resident is away and can't do it. So I do prostatectomies once in a while, but not very frequently. And also a transurethral resection of the prostate, or a TURP. So a prostatectomy can be done open or it can be done robotically. We do them in my facility. We do them robotically, and they go really, really well. But like I said, I've only really participated in a handful, maybe 5 or 6 over my 10 or so years in this position. But they're a good case, and patients do pretty well. All right, let's move into the scrotum and the testicles as we move down through the genitourinary system. Testicular torsion is our next one, and it's a good one to just hold in your head. I feel like it's something that, I don't know, I feel like it's easy to ask questions on so that it comes up a lot. I could be making that up, but it totally feels like it. The highest incidence here is during puberty. So again, 80-year-old man comes in with an issue, probably not testicular torsion. Possible, but probably not. 13, 14, 15-year-old comes in with severe acute abdominal pain, nausea, and vomiting. You need to be thinking testicular torsion. Severe acute abdominal pain, nausea, and vomiting. Labs and studies. And physical exam findings. This is pretty straightforward stuff. Again, this is not real complicated. So this is where I push thinking instead of memorizing. I'm all for memorizing facts and knowledge, but I think we overdo it, and we're not as good at it as we think. And if we can use thinking when we forget something, and as we're bound to do, we can still come up with answers. So if we have a torsed testicle, the affected testis will be firm and tender, and usually a little higher than it should be. Makes sense. Now, if you lightly stroke the superior medial thigh, the cremaster muscle should pull the testis up on the side that was stroked. Unilateral absence of this is 99% sensitive. So we've got a simple way to diagnose testicular torsion. Another way is called PANCE sign. Which is when you elevate the testis, the patient will feel better. They'll get some relief. Now, it's not entirely helpful because it'll be positive in testicular torsion and in epididymitis, which we'll get to in the next show. But it's certainly helpful, right? We're not always looking for definitive answers. We're looking for a direction of our diagnosis. We're also looking for the little things in the questions that will point you toward the diagnosis or away from a diagnosis. They may not give it to you, but they help to confirm something that you're thinking. Same thing happens in the clinic. Same thing happens in the ER. I kind of think this is a testicular torsion. The cremasteric reflex is positive on this unilateral side. It doesn't move, but I can't tell for sure because it's a 12-year-old boy and he's uncomfortable and he's wriggling around and it's hard to tell. Well, what about if we elevate the testis? Will he feel better? And he does. Does he have epididymitis? He might. But in a 12-year-old boy, that seems unlikely. Possible, sure, but unlikely. It's not definitive, but it's helpful. Now, what is our definitive test here? Again, think this through. This isn't hard. If you want to check blood flow to the testes, because in a torsed testicle, right, it's spun on itself. So the blood supply has been cut off, just like a torsed ovary. How are we going to test for blood flow? What's the easiest, simplest way to check blood flow? Especially in an area that is not deep to the body. Well, we can do an ultrasound, right, with a Doppler, and we can check the blood flow and get a very, very definitive answer pretty fast. Right? That's not that complicated. It's not invasive. Treatment. Manual detorsion of the testes. So you're going to spin them. And the way you're going to do that is like opening a book. So think about the way your hands would turn to open a book. That tends to be the way to be the opposite way that the testes will have turned. The other is getting to the OR as fast as possible and surgically correcting the problem. So that's what we do with the torsed ovary. You go in laparoscopically and you unspin it. Blood flow returns. Everybody's happy. Same thing here for a torsed testicle. But this is a surgical emergency at the time of diagnosis. Right? Anytime we have a decrease in blood flow, not just a decrease, but a cutoff of blood flow to an organ, we have a surgical emergency. Right? That's really, really bad. And there's a time limit attached to it. And getting things done in the OR takes time. The patient has to be transferred. The nurses have to accept the patient. The patient has to be brought to the operating room. The patient needs to be put to sleep. All of these things take time and the clock is ticking. Now, can you do all of those things faster? Absolutely, you can do them faster. Can you skip steps? I guess you can, but you don't want to. So these patients need to get moving very, very quickly. All right, a couple more issues in the scrotum, and we will be done for today. So we did testicular torsion. Let's talk about a spermatocele. Spermatocele is a benign cyst within the scrotum that contains spermatozoa. Clinical presentation, usually it's a routine physical exam, typically painless, although may be palpable or uncomfortable if very large. These will transilluminate if large enough, and they may be palpable on physical exam. An ultrasound will tell us a lot more about what we want to know here. Most commonly, these are left alone. Or alternatively, you could do a spermatocoelectomy, which is really fun to say, so you might want to go for that option. Hydrocele, a collection of serous fluid within the scrotum. The clinical presentation here, again, a routine physical exam, typically painless, though may be palpable or uncomfortable if very large. Just think about a cyst within the scrotum. It's something you can kind of feel, and it's kind of heavy. And these also will transilluminate if they're large enough. Maybe palpable. Ultrasound will tell us a lot more about the situation. We can do a surgical removal if we want to. Varicocele is next. This is an enlargement of the venous structures within the scrotum. This causes like an ache, and the patient can usually feel like a heaviness within the scrotum. The term that goes along with this under physical exam is a bag of worms on palpation. Just think about engorged veins within the scrotum, how that would feel, right? So a bag of worms sort of makes sense. And unlike the last two, this will not transilluminate. Hopefully you know what transilluminate means. I'm skipping right over that. I found recently a lot of pre-PAs and first years have been listening. So let me back up and go over that just for a second. Transilluminate means, very simply, you'll put a flashlight up to the scrotum and it will glow with the light, or it won't if the light's blocked. So I'm trying to think of an example off the top of my head of something that an analogy that would fit to this. The only thing I can come up with, and I may lose you just even worse here, is when we do laparoscopic surgery. If a patient is really thin and we put the ports in and we inflate the abdomen, and then you put the scope in, which has a big flashlight on the end of a camera, right? The abdomen transilluminates. You can see the abdomen glows with that light because you can see the light coming through the abdomen. If the patient is very heavy, has a BMI like 45, 50, the abdomen will not transilluminate because the fat and all the tissue will block the light. So what we use the term in surgery a lot, transilluminate, is when what we're doing is you're looking for, before you put your port sites in, before you cut the skin, if possible, you can transilluminate the skin from inside, and you can actually see the blood vessels in the abdominal wall, so that when you make your incisions, you can try to avoid those. So you can transilluminate the abdomen in order to put in better port sites. In this case, we're holding a flashlight, holding a light up to the scrotum and seeing what happens. If we have a hydrocele, right, we have fluid. So the fluid, the light will pass through and it will transilluminate. A spermatocele will do the same. But a varicocele, we're talking about veins. So we're talking about blood vessels filled with blood, not water. So these will not transilluminate. And again, to me, these are not things you memorize. These are things you understand, things you think about on test day. A varicocele is not necessarily a problem in itself, but may cause decreased sperm count due to elevated temperature, right? If you have an increased blood supply in that area, the temperature may go up. Removal of the venous plexus is possible, but treatment results are questionable. Our last one for today is spermatocele, benign cyst with the scrotum which contains spermatozoa. Oh, somehow I have that doubled in my notes. So we're done. Even better. Looks like I get to let you out early from class today because I thought we were going to be here longer. So that was spermatocele, which is done. Excellent, excellent, excellent. All right. Well, before we finish up, we have our priming questions, and I do want to talk about one particular idea when it comes to studying and when it comes to your tests. And this idea is something that I've been pushing, but it was brought more to my attention and stated more plainly in a book I just finished called A Hunter-Gatherer's Guide to the 21st Century, which I strongly recommend, really good, subtitled Evolution and the Challenges of Modern Life. by Heather Hengwing and Brett Weinstein. Excellent book looking at there are two evolutionary biologists who are looking at our modern world and reviewing the things that we do and the things we have stopped doing through an evolutionary lens. It's a good read, a good way to look at some ideas from a new perspective. You may not have put on some new technologies and ways we have of doing things, cultural aspects and so forth. Anyway, that's not the point. The point is they did a small section on school. And historically, from an evolutionary standpoint, how new school is to humans. And even if you look around the world, how many cultures don't have a schooling system like we do here in the United States or in other countries around the world. So what they were one of the points they're making, and it's something you can't help but notice, but I think some people don't notice it, is that our school is a reductionist system. And what I mean by that is it takes wisdom and breaks it down into these little chunks and then tries to get it into your brain and then get you to spit it back at. And that's how you're graded. That's how you're taught. That's what we call success in school. We've created a system that's almost like a game. And if you learn that game, you can do well. But if you don't learn the game, and if you think it's about gaining wisdom and gaining understanding and gaining knowledge, you may struggle. Now, I get those are higher ideals, and that's what I want for you also. But it's not the way our schooling system tends to work. You know, when they talk about in the book the idea of a reductionist thinking or reductionist system, what they're talking about is instead of eating food, you're having a protein shake. But the protein shake is not the same as eating real food, right? We all get that. Taking a vitamin pill is not the same as getting your vitamins from a food source. So in our modern world, we like to reduce things for easy consumption. And that's what schools largely do. They reduce knowledge, they reduce wisdom for easy consumption. And then we teach, and then we create tests so we can measure that consumption. We create these metrics, but essentially the metrics are false metrics because they don't test you on wisdom or your ability to think. They test you on this reductionist thing they've taught you. And please understand, I'm not saying that this is all bad. Not at all. I just want you to be aware of it. Because I know some students get very frustrated with the progress that they're making because they don't understand the game. They don't understand the system. So I want you to be clear on what the system looks like, what your school is trying to show you, and then how you're measured, and the metrics used to track your progress. You know, I hear from students, one of the first things, almost everyone, when they email me and say, I failed the PANCE. I don't understand. All my patients love me. And they can't separate those two things in their minds, and I try so hard to convince them that the PANCE is a metric. That's all it is. It's a tool to measure what you've memorized during PA school. It has no ability to judge you on your patient care, no ability to judge you on your personality, on the connections you build with your patients, on the empathy you have for your patients. None of that is tested. The only thing that's being tested is, can you regurgitate data that you've been shown? And people get very frustrated because they don't understand the game. And I want you to understand the game so you can win. It's extremely important to me, and it's extremely important to you. Again, it doesn't mean that it's bad. This is also why you do rotations. Rotations are designed to bring in wisdom, to bring in experience. It's a huge part of your schooling. When most of the didactic years are spent acquiring knowledge, acquiring facts, with almost no attempt to acquire wisdom. That's on you. But please understand, when you take tests, you're studying with an eye to this reductionist ideal. That's why I talk about here on the show, don't look for the outliers. The outliers may matter in a clinical setting, but on your tests, focusing on the outliers takes up too much time and too much energy. They're generally not thinking that way. They're generally not creating questions for you to look for the 1%. They're looking at the 80 to 85%. They're looking for the man with BPH who's 80 years old, the testicular torsion in an 18-year-old. That's what they're going to ask about. The test question should be pretty straightforward. I know that you won't know all the information, but they're just spitting facts back at you. It's just a game. And I think understanding that it's a game and that you can win at it helps. All right, let's answer our priming questions. Hopefully these should be pretty easy. What type of incontinence does BPH cause? What type of incontinence does BPH cause? Overflow incontinence. We talked about that in detail. If you didn't get that, go rewind this maybe and listen to it again, and maybe the last episode as well. On physical exam with scrotal, I really muddled that one up. On physical exam, which scrotal issue will transilluminate? Hydrocele, varicocele, or spermatocele? Well, there are two, right? Hydrocele and spermatocele. The varicocele will not transilluminate. What is the name of the reflex that results in the testes being pulled up? The cremasteric reflex. All right, we nailed that one. Excellent. That was a lot of fun. Thank you so much for showing up today. I really do appreciate you being part of the community, you being part of our system here, and you growing throughout PEA school and throughout listening to this show. And it just makes me really happy and thrilled to have you on board. So thank you so much for that. Now, like I mentioned in the beginning of the show, two things I want you to be able to do. One is help me and help someone that you know and share the show with them. That is a fantastic way to, like I said, help me and help somebody else. And the other thing is, if you want to get every single episode of the show, go over to www.physicianassistantexamreview.com/podcast to get that. And next week, we'll continue with the GU system. Take care.